Hello, as we start into mental health, we're starting with Module 28 to talk about the mood and affect. So, some of these words, mood, affect, emotion, have been used interchangeably, although they have slight differences. So, your emotion is a conscious reaction, it's automatic. And then your mood is, well, emotion is immediate, short-lived, and I said reaction, where your mood lasts longer. Rather than a distinct reaction to something, it is more of a long-term, not quite so obvious, and it can last for a period of time. The mood is less intense than emotion. It doesn't always need something to cause it to happen. And then you have your affect. Some things say that it's unconscious response. Some things say it's a conscious response. Most of what I found talks about it being unconscious, and that's what your text says, that it's an unconscious response. It drives or forces the resulting emotion. Your affect is something that you can appraise or observe. It's how somebody observing you will say that you appear to be feeling. It's your demeanor. It's complex. They judge it by your demeanor, the tone and modulation of your voice. So on this slide here, talked about a positive emotion and positive mood. So the positive emotion, specific event, where mood is more general and unclear. Emotion, brief, and mood, longer. Emotion is specific, event, reaction is specific, feeling, and the mood is more generalized. Okay, let me keep going, and by the time we get done with these, this should hopefully be clear. So, defining mental health, a state of emotional, psychological well-being in which an individual is able to use his or her cognitive and emotional capabilities, function in society, and meet the ordinary demands of everyday life. That is the biggest thing, being able to function, use their cognition, their thinking, their emotions, and being able to function in their activities of daily living. That's mental health. Mental illness is a condition that affects the emotions, thinking, behavior, or a combination of all three. And as we cover different things and different disorders, that will be clear. The word in your text over and over is mental illness, and a lot of things are trying to pull away from that terminology of mentally ill, as in we just really focus on mental health. But mental illness is, as I said, a condition that affects your emotions and thinking. And the more it impacts your ability to function or not able to function is the increased severity of that mental health issue. Okay, so moods. Page 1910 and 1912 have sections that discuss your moods. Euthymia is a stable range of neither depressed nor manic. Fluctuations are appropriate to the situation. Depression is thinking of depressing, pushing something down, so it's abnormally low mood, sad, empty, irritable. Mania, the opposite of that, abnormally elevated, that impairs ability to function. It lasts at least a week. Mania is not just a hyper episode. it is lasts at least a week, and it's abnormally elevated, expansive, persistent. And as we talk about different disorders such as bipolar, we can talk a little more about mania. Anhedonia is a term used often in mental health, just in health period. It is the loss of interest or inability to express pleasure, fatigue, sleep. They have fatigue, sleep disturbance, and somatic complaints. So the somatic complaints is when you have multiple physical complaints that are actually linked to the emotional state. Hypomania, opposite of mania, is this total lack of energy, low function level, and it must last at least 4 consecutive days. Anxious distress. It's a combination of symptoms: restlessness, impaired concentration. It's due to worry, fear, sensation of doom, fear of losing control. It's an anxiety level that causes emotional distress. So, when evaluating, you're looking for appropriateness or congruence. You want the person's affect, how they appear, present, how they, what your appraisal is of how they're feeling should match what they state they are feeling. That's congruence, that they come together. And we should have a broad affect, meaning that our affect, our appearance, our appraisal that comes across us should be able to fluctuate as our moods fluctuate. Okay, so characteristics of a normal mood is this broadness. It's appropriate or congruent to the situation. It is a response that is proportional to the stimulus. So if somebody comes in and they hand me a rose, I go, "Oh, that's really nice. It's very pretty. Thank you." Versus, "Oh my gosh, you actually got me a rose. A rose. How could you do?" That's not quite in proportion to somebody handing you a rose. Or you stub your toe and that hurts and it's upsetting versus falling down, crying, falling apart because you stubbed your toe. That's not in congruence with the situation. There is no dramatic or rapid shift of your affect or how you are presenting yourself. So there's different types of affect. I'm going to go on the next slide here. And affect is discussed on page 1910. This picture is good. So there's a normal affect, a constricted affect, a blunted affect in this picture. So you would expect the first picture, if I won the lottery, that would be my face. I'd probably be jumping up and down. Constricted is like they're holding back. And blunted is like flat. They're not showing anything. So in your text, it has moderate. The individual displays a level of emotion that is appropriate to the situation. I would say that's normal affect, moderate. Overreactive, the individual's level of emotion is disproportional or extreme given the situation. That would be what I was talking about with this overreaction to a situation, positive or negative. Blunted, the individual displays a level of emotion that is dulled or muted. Muted is the best word for blunted. If you look here, it should dulled or muted. I guess that's the best word there, because flat is there's no visible cue to any emotion. Here you can almost see an emotion in the eyes, but it's really dulled. And then flat is flat. If you've ever met anybody with a flat affect, sometimes you will see that with different mental illnesses. Sometimes the medications will cause this very flat, they talk monotone like this, there's no facial expression, the skin doesn't move, the eyebrows don't go up, the hands don't express. I'm very expressive with my hands, but it's just dull and they're just there, blah, blah, blah. Blunted is not quite that extreme, but it is suppressed. Factors affecting mood and affect, page 1911 to 1912. So the factors that affect it: your neurological, your neurotransmitters, the activity and the receptors to these neurotransmitters contribute to the development of mood disorders. That's where the medications, serotonin, norepinephrine, dopamine, and acetylcholine come in. And as we cover disorders, we will talk about some of those things and medications, because the medications are specific to these neurotransmitters or helping with the receptor sites. Personality: emotional instability, introversion, low levels of conscientiousness. That's your personality. And so your whole mood and affect is very impacted by your personality. So if you're neurotic, you're going to be very emotionally unstable. There's some people that are ridiculously outgoing, and their affect may be very high all the time. There's people that are so incredibly shy and withdrawn that they come across as like maybe even a dulled affect because they are so withdrawn. Stress. Stress does a lot of things. You guys are nursing students. You know. Stress can cause you not to be able, excessive stress, to adapt to situations around you. And you may find that you overreact to things because your stress level is so high. If stress is chronic, persistent, it leads to hormonal changes and the whole function in the brain changes. And that's when you get into things such as PTSD, post-traumatic stress disorder, because of this thing that goes on, and it affects your sleep, affects your ability to communicate, it affects your reaction to other people, your reactions to everything's around you, your ability to eat, your desire to eat too much, to eat nothing. So that's all stress related. Social interactions. Social support, interaction with other human beings totally impacts our mood and affect. Lots of studies have been out there and things have been seen on like children and child abuse, neglect, that leads to alterations in their mood and affect, in their whole mental health. So even it's our social interaction can even be our perception of if we feel we are supported in our social environment will impact our mood and affect. Day and time, the day of the week, the time of the day, the time of the year. We have hormonal shifts, everyone, male and female. We have our normal circadian cycle that runs for 24 hours, and it's regulated by our several hormones. The main ones that I'm thinking of are your melatonin and your cortisol, and they fluctuate through the different times of the day. So no matter if you work night shift, your cortisol level is still going to spike like I think it's like 6, 7 a.m. Whether you work in night shift, day shift, evening shift, it doesn't matter. These hormones are still going to do their normal fluctuations. We're affected by the sun and the light. It affects our whole mood. So living in areas like Alaska that may have long, long periods of darkness affects the mood. There is more depression, like we will later talk about seasonal affective disorder, and it's affected by the season. And as things die and it gets darker, longer, the person's mood goes down. And as the sun starts coming out and things start livening up, their mood starts livening up. Gender and age. Women are more likely to physically express their emotions and are more comfortably discussing their feelings. And sometimes that's perceived as bad, sometimes that's good, sometimes it's our cultural background of whether we feel okay about expressing how we're feeling. Our age has a lot to do with it, especially adolescence when hormones are surging all over the place, when women start going through a hormonal change again with menopause, even males as their hormones are shifting in middle age. As we get older, as I'm approaching those ages where, different aches and pains and everything that affects your emotions, your mood, and your affect. Illness status. The better we feel physically, the better our emotions and moods are going to be. So if we're chronically ill, that wears us down and affects that long-term mood and will affect the affect that we express. Let me look back at my notes, make sure I covered. I was just sitting here talking away. Stress can be excessive, can lead to maladaptation. I said that, I believe. We need social interactions, need social support, positive social interactions, hormonal fluctuations. Women are 2 times more likely to have mood disorders. Women tend to internalize and hold onto more guilt. Oh, and there is, on your physical illness status, there is a link between autoimmune disorders and mood disorders. Okay, so health promotion. Page 1919 in your text. Improve food choices. Things that affect our mood and our emotions and are your food choices. Sugar, saturated fat, and refined foods. All of those can negatively impact our physical health, also our emotional state, and both can aggravate the other. So for health promotion, encouraging decrease in sugar intake, saturated fats, and decrease in refined foods. Need to increase our fruits and vegetables, legumes, nuts and beans, fish, and whole grains for our health state, which also affects our hormonal state, our weight, and our sleep, and our physical wellness, which affects our mood. Vitamins, omega-3, fatty acids, folic acid, vitamin D, calcium are all beneficial to our health and our mood. We need adequate sleep. There is no such thing as I only need 4 hours sleep, I only need 6 hours sleep, or elderly people do not need as much sleep. And we probably talked about that in fundamentals. We really need 8 to 9 hours sleep regardless of our age. The younger child that is growing may sleep longer. Teenagers tend to sleep longer. They need more sleep. And as somebody gets older, they don't need 5 and 6, they still need that 8 hours of sleep because that will affect our health and our emotions and our hormonal levels. Regular exercise, it doesn't have to be running, it doesn't have to be working out at the gym. It just needs to be physically active a good 20 minutes every day, and that affects our emotions and moods. Smoking. Smoking cessation is very, very important. The nicotine affects vasoconstriction, so it actually affects our blood flow, our mentation in our head. The smoking affects the lungs, your lung capacity, your ability to do things, and smoking will negatively impact your ability to sleep. Okay. Depression screening. There are a bunch of depression screening scales. We're going to talk probably most about the PHQ. The next slide is a PHQ, and I loaded a PHQ onto Moodle. There's a PHQ-2, which is a screening of 2 questions. If you answer yes to either of those questions, you go on and do the rest to the whole PHQ-9 to get your risk of where you are emotionally, and as far as like depression, being mild, moderate, severe. And then the geriatric depression scale in the next thing when we talk about depression in the exemplar A, I think it is, we'll talk about the geriatric depression scale or the GAD, G-A-D. Okay, those are the main ones I will be focusing on. Sorry, just realized I skipped over here. These tools, table 28.1. Let me flip over and look at this. So there's table 28.1 on page 1921. Okay, so with children, you're going to use a different questionnaire to evaluate their emotional state or their depression screening, bipolar screening. Your adults, the PHQ-9 is very common. I've seen the Beck depression inventory, but the simple PHQ is something as an RN you will do. You will do it in multiple settings. You probably will do the screening. They usually have screening everywhere you go. When you're doing any kind of intake or history, you're going to do a PHQ. Whether you're working in an office, in a hospital, especially home health, you will do a PHQ. You don't need an order to do that screening. And you can do the 2 and continue on to the 9, but if your gut's telling you something, do the whole 9. It's a very easy questionnaire. Older adults, I call it the GAD, GDS, it says in here, Geriatric Depression Scale. And we're not going into the postpartum depression in this course. Okay, so there's your PHQ. I said sometimes you do a screening. It's just these first 2 questions. A lot of built-in EMRs will have these 2 questions pop up as part of your routine. Little interest or pleasure in doing things, not at all several days, more than half the days, nearly every day. Feeling down, depressed, or hopeless. If they answer anything, 1 to either of these or more so, it will trigger you automatically and the rest of the questions will open if you're in a built-in MAR. I'm not MAR, EMR, electronic medical record. Okay, the next slide. We are almost done with this. So your nursing assessment. Nursing assessment starts on page 1921. There's some things I'm going to cover here, and some of these pieces will be covered in the other exemplars. So observation and patient interview. Observation is very important for you to watch and assess, evaluate their affect And what they're telling you, is it matching how they're expressing themselves or how they look? Are they telling you this terrible story with a big smile on their face? Or are they looking really sad, but they're telling you something that should be joyous? You're observing their how they approach you, what they look like, if they have family members with them. Are they interacting with the family members? Is there anger present? How are they dressed? Is their hygiene good or poor? Nonverbal communication. Are they irritable? Do they appear exhausted? Are they excitable, grandiose, um, pressured speech, or just talking like it's just very hard to get it out? Or are they seeing and talking about things, or talking to things or people that aren't there? Are they psychotic? You need to go and get their medical and their mental health history. If they've had any mental illness, medications for it, previous treatments, is there a family history of that? Their problems in their daily living, how is their eating patterns, sleeping patterns, functional patterns? Are they able to work? Are they able to take care of their house? Can they get through every day? Can they cope with things at home? Or their financial status, their home environment, self-reporting scales for depression, or you can do the PHQ. They can fill out a PHQ. Cultural considerations, or is it actually the affect is off, or is it their culture of how they're expressing or not expressing themselves? And of course, you need to do physical examination, looking at their vital signs. Pain is the fifth vital sign. Pain can totally impact your emotional state and how you're expressing yourself. Rule out if there's any medical or drug-related causes for what you're seeing. Are they on a medication, or pain medication, an anti-anxiety medication, something that is flattening that affect or elevating it? Your diagnostic tests, is any testing that has been done to rule out any underlying medical condition. Even sleep apnea, which impacts their sleep, could be affecting the whole mood and the ability to cognitively function. Electrolyte disorders, liver enzymes elevated, that's causing uh, elevated ammonia level in the brain. So ruling out other possible causes. Independent interventions, that is page 1923. There's a whole box 28.1, and preventing inpatient suicide and promoting safety. There's a whole prevent suicide and promote safety section. So you're assessing prevent suicide, promote safety. The risk increases as the patient improves. With suicide or suicide risk, confidentiality does not apply. The patient's safety comes in first. Here in box 28.1, let suicidal patients know the environment is safe for them. Do not leave the patient at risk for suicide alone. Family members cannot substitute for staff in performing one-on-one observation. Be very alert during change of shift, because they know there's a distraction there and they may take advantage of that. Examine everything brought in by visitors and monitor for safety. Sometimes they mean well and they may bring somebody's medications or a drug or something in, and sometimes they don't mean well and they're bringing the wrong thing in. Facilitate the development of a therapeutic alliance and maintain a non-judgmental attitude. Use calm, reassuring approach. Okay, so monitor patient response to treatment. It is okay. It is important to say, are you thinking of hurting yourself? Do you have a plan to hurt yourself? Have you ever attempted to hurt yourself before? When was the last time you did it? How did you do it? Because as we talk more later about suicide, that is extremely important. Support family functioning. Have family be present if possible, if that's not detrimental. Teach assertive behavior. Teach them to speak up for themselves. There's a difference between assertive and aggressive. Aggressive is not a good thing. Assertive is standing up for yourself. Aggressive is more maintain professional behavior. Short-term relationship. It's very hard as a nurse sometimes to cut it off, but you have to keep that nurse-patient distance and avoid dependence. A lot of times with mental problems, emotions, they get very attached to whoever's helping them work through it. So you need to push that distance there, but tell them that you're listening. There is to be no social contact whatsoever with your patient. Looking page 1924, professional behavior. So collaborative therapies, all this pharmacological and other things and the medications, I am going to put these in as we talk about the other modules in this concept of mood and affect. So that is the end of this lecture.